Hello, my name is Dr. Barry Katzen. It's a pleasure for me to be able to share with you some information regarding renal angioplasty in patients with fibromuscular dysplasia. Sorry I can't be there in person, but hopefully I'll be able to convey some information for you. I think everyone in this audience certainly is an expert regarding fibromuscular dysplasia and the abnormalities that we see. And typically when it comes to renal vascular disease, we see this very irregular string of beads on images such as this, a CT scan of the abdomen. As you know, it's a result of abnormal growth of the fibrous muscle layers within the wall. It's not considered an inflammatory disease and it's not atherosclerotic, but it usually results in narrowing of the renal artery. And the end results may include occlusions, dissections, and even emboli that can occur. And it's most frequently noted in middle-aged females. Now, the reason it causes high blood pressure is that there are hormones created in the kidney called renin. It's the name of the hormone. And when the kidney senses that it's not getting enough blood flow, it puts out this renin, which elevates the blood pressure in the aorta so that the pressure in the kidney can be maintained. And here's some different examples of different types of morphologies. String of beads here, a little bit of ectasia or small aneurysm formation. And here you can see a nice example of how these zigs and zags and in the string of pearls or string of beads configuration alters the renal artery. These webs produce a narrowing that causes the kidney to sense it's not getting enough blood flow. It can be unilateral or bilateral, and of course can affect a lot of different blood vessels. We're going to focus here on the renal arteries today. Most common form that we treat is called multifocal and the string of beads appearance. The third therapeutic goal is to disrupt these bands and webs and create a smooth lumen. But in reality, we learned early on that getting a perfectly looking picture is really not the objective. It's better to rely on subsequent healing of the angioplasty site, which occurs over time. So we're not looking for a perfectly a smooth appearance. We're generally not going to see that at all in the FMD lesions. Generally, angioplasty alone is sufficient in this disease. That's the good news. There's generally not a need for an implant, a stent, but occasionally we will need to put a stent in, particularly if there's a dissection or the fibromuscular scirrhus type of FMD that's resistant. Believe it or not, it's more common that we use stents in children because of the nature of their FMD and being more fibrous in nature. I thought I'd share with this with you. This is a newspaper article involving the first patient that I was involved treating. You can see it goes back quite a way in 1978. And this was a very big event at the time because up until that time, the only treatment was open surgical correction and a variety of different techniques. So this was a real milestone to be able to do these first patients in Northern Virginia. As you know, it's common in young people and in females. It's often in the mid or distal part of the renal arteries producing the string of beads. Many times it's totally asymptomatic, but it also is a cause of hypertension and commonly poorly controlled hypertension. It's unusual for FMD to lead to renal failure or renal dysfunction, in fact, but longstanding hypertension, of course, can lead that. It's difficult to assess angiographically, and we do use hemodynamics using pressure wires, and intravascular ultrasound can be helpful as well in terms of really understanding the severity of the disease. Again, I mentioned that angioplasty is the treatment of choice. Now, as you can see in this image, it's not uncommon to have aneurysms associated with FMD. This one's a pretty large one. It represents a risk of rupture, but generally the small aneurysms, in fact, don't represent that risk. When we do angioplasty, it's done under local anesthesia. We can make patients quite comfortable using mild conscious sedation. We can approach from the femoral arteries or the upper extremities. More commonly lately, we have been using radial artery access, which has some advantages to femoral artery access, but I think the access is really not the important thing. It's really an operator preference, and whatever is most comfortable doing. Either way, it can be done in an ambulatory environment, particularly if malignant hypertension is not present. Most of these patients are treated in an outpatient environment, but someone who has really severe hypertension, we generally prepare to stay in the hospital overnight, because once the renal arteries are opened, then blood pressures can fall precipitously, and you can actually get sort of erratic blood pressures. I mentioned the radial artery. You can see in very steeply downward directed arteries, it's renal arteries. It's somewhat easier to come from above. Also, in patients like this whose iliac arteries are occluded, it's technically easier to come from above. There are basically two technical ways to do this: the so-called sort of coronary way, where we put a guiding catheter in and use smaller catheters and balloons to cross the lesion, and then the traditional one where we just use a regular guide wire across the lesion and then use a balloon. I mentioned radial access, and this is really just showing that the frequency of femoral access is decreasing, but it's still commonly used. Again, I would say it's up to the patient's, the operator's skill. Here's an example of what we do if we're going from the radial artery. We always want to make sure patients, especially women, have appropriate sized radial arteries, because the radial artery can be occluded as a result of this. And particularly women who have smaller arteries, we need to make sure that they're open. This is called an Allen's test, where we actually test whether there's collateral flow, so that in the event that the radial artery is compromised, there's no symptoms in the hand from ischemia. And so we produce an occlusion, and then we release, and we're able to demonstrate that the hand does get blood flow. This is just a little bit more on the technique, where we compress as we're getting ready to put the sheath in. And you can see these are relatively short sheaths that go into the radial arteries. And the advantage of this is that we can pull the sheath out, and patients can ambulate right away. That can be challenging in hypertensive patients, because when you first get up after a renal angioplasty, when we're treating hypertension, hypotension can develop, and patients can get syncope or faint, actually. So we have to be very careful as the blood pressure re-regulates itself. Generally, we will do an aortogram first, not just go to selective studies. And one of the reasons is we need to make sure there's no disease here in the ostium of the renal arteries. Here you can see an aortogram that demonstrates a couple of interesting things. On the right here, there are two renal arteries, one here that has a string of beads, and another one that's very small lower renal artery that actually has a branch right here that's kind of filling, that's stenotic and filling backwards. This particular patient has actually 4 renal arteries on the left side, so there's a total of 6 renal arteries. This can be quite complicated to treat, and when we're treating hypertension, it's important that we assess each and every one of these, because we may not be sure which one is the culprit. Now, I mentioned different techniques. On your right here, this is the traditional and the first technique that we had originally, where we cross the lesion with a guide wire, and then use that guide wire to track a balloon over it, and then do the angioplasty and pull out. This is a technique that we use in the heart, where we put a guiding catheter that remains positioned at the ostium of the origin. We work with smaller caliber wires, and then work through that guiding catheter to put a balloon or a stent in. Pressure measurements can be done at the time they confirm hemodynamic significance of a lesion. It can be a little artifactual, because the catheter itself can induce a pressure gradient. But we now have pressure wires that are available to confirm whether these lesions are hemodynamically significant. And it can be technically challenged to cross these webs with these small wires. Here's an example. This is actually more of an atherosclerotic lesion, but a pinhole lesion, you can see it would be very difficult to cross this area. And this is what it looks like after, in this particular case, with stenting and balloons. Just so you're aware, this is the placement of stents. They're used for refractory hardening of the arteries. This is an embolic protection device, which we don't really use very often in patients with FMD for a number of different reasons. But just in case you hear about it, that's what it looks like. Now, managing patients with FMD and hypertension is really an art form in itself. We generally hold the antihypertensive medications the morning of the procedure, particularly the short-acting ones. Beta blockers we generally don't hold because they have long durations of action. It is important that patients be on aspirin plus or minus Plavix, antiplatelet agents, because women and particularly FMD patients are prone to develop blood clot and platelet aggregation. We use anticoagulation as well. And after the angioplasty is successful and the artery is open, patients can experience hypotension because of the nature of the hormonal changes. And so we generally use volume expansion, where we give intravenous saline for 200 to 500 cc's right after the procedure. And this is to promote a gradual decline in blood pressure following treatment. Patients are generally done as an outpatient, but kept overnight, as I mentioned. As with any vascular procedure, you can have bleeding or blood clots occur at the site where the catheter goes in. In patients with FMD, there can be risks to the kidney, which include infarction or embolization into small branches, the development of spasm, and the presence of rupture, actually, which can be a very significant issue because it would involve bleeding. Most of this can be controlled with catheters without the need for open surgery. And these complications are pretty rare in FMD patients, probably 1 to 2%. Here's an example of a patient who had a rupture where the guide wire went out of a branch, and this contrast is essentially bleeding outside the kidney. We've associated with this with certain particular types of guide wires, and this is sort of a preventable complication, but it can happen. This 47-year-old woman with hypertension and a blood pressure of 180 systolic had become well controlled, but now is on 3 antihypertensives that you can see here. Her mother and father required blood pressure medications at approximately the age of 45. So there's a very strong family history. Now, generally, when there's FMD in this kind of historical environment, the FMD is actually not the cause of the blood pressure, but sometimes it's difficult to be certain. Patient like this, we look by ultrasound first. In this particular case, we can see a disruption of the color flow in the mid portion of the renal arteries. Renal ultrasound demonstrated elevated velocities and some other ratio abnormalities. And of course, the angiography demonstrated a very classic string of beads. Where's the narrowing here? Where's the critical narrowing? It's very difficult to tell. It could be right in this area where this web is. It could be right here, this web before that string of beads. And so as a result, we put a wire through here and we treat the entire segment of the visible FMD in the renal artery. We always look at the other renal artery. Here you can see it's perfectly normal. This is what the artery should look like. We not only look here where the common FMD is present, but we also make sure that there's no narrowings in these branch stenoses. Then we come back to the culprit artery, as you can see here on the right side. This particular case has a guide catheter and a small wire and a balloon placed. You can see the balloon in position placed into the area of FMD, and here's the guiding catheter that's demonstrated here. And here's what you can see afterwards. And maybe to your eyes, it doesn't look any different because we see this irregularity, but those webs that were going across the whole thing is gone. We generally in terms of balloon sizing, we monitor the patient's discomfort to make sure it's the right size. But when we do follow-up angiography in patients like this, we will see this FMD smooth out. In this particular case, we went out and repeated the angioplasty with the same size balloon to smooth out the artery a little bit more. It looks a little bit better, but we generally feel perfect is probably not the result we're looking for here. We know the patient's blood pressure will respond. I mentioned intravascular ultrasound. It's very helpful in atherosclerotic lesions. It's somewhat helpful, and this is a beautiful demonstration of one of these webs. And this is a cross section of an artery, and this is what it looks like after the angioplasty, where you see that web has been is now discontinuous. Follow-up on the patient I showed you is blood pressure became stable with a blood pressure of 110 to 120. A vascular medicine consultation was conducted, and the patient was going to be seen in 3 to 6 months. Here's an example, another patient with uncontrollable hypertension. You can see here there's a string of beads, a little bit of an aneurysm formation here. But on the right side, it looks much more severe. There's an aneurysm that's forming, and you can see that there's delayed flow. The blood flow is washed out here on the delayed images. And so this is most likely in this area where the stenosis is, because the flow is diminished in that segment. And so we decided to treat the FMD in this segment. And here you can see what it looks like post, in this particular case, a 7mm balloon, little outpouchings, but no more webs. This looks like a good result. We elected to leave the aneurysm there, which is generally what we do with the initial therapy. And in this particular case, we treated both sides because we couldn't be certain that there wasn't a web hiding here on the left side. And so we're left with this aneurysm. And a very common issue is in these aneurysms, when do we treat? Do we treat it now? Do we come back and leave it later? Is the aneurysm going to get smaller, in fact, because the cause of the aneurysm is gone and it's not under high pressure anymore? And generally, we sort of wait and evaluate, and elected to delay that. And finally, I want to share one more case. This is a 51-year-old woman who we treated recently from Sarasota. She was diagnosed with hypertension in her 30s and was on multiple medications for the last 10 or 15 years. But recently she developed unexplained flank pain and had actually a significant enough pain to go to the emergency room as a result of the presence of this pain. On her CT scan, you can see that there's an aneurysm in the left renal artery, and there's findings of fibromuscular disease in both renal arteries on the CT angiogram. She ultimately, there was a lot of discussion about different treatment options. Ultimately, she came to us for treatment. Here you can see on the left side, there's an aneurysm, and she had FMD here, and there was a very tight jet that was going into this aneurysm. Here you can see a closer look at that, a web here, a web there, and here's the aneurysm. We were uncertain as to whether this was causing her pain, in fact, because it's most of the time these are not symptomatic. And she had a significant hemodynamic FMD here on the right side. You can see going into a branch, a little closer view of that. So we elected to actually treat the right side first, which we did here. And this is what it looked like after the treatment. Again, it doesn't totally go away. We rely on long-term follow-up. And here you can see the measurement of that and the aneurysm on the left side. We treated that with this balloon, and we got a very good result. And then, of course, her blood pressure improved gradually over time, and I'm happy to report that she's still off of medications, exercising without symptoms, and feels incredibly good. And the amazing thing is her left flank pain disappeared. So why did she have pain in the first place? Probably as a result of increasing pressure on this aneurysm. So at this point, we haven't treated the aneurysm. It's going to be undergoing surveillance, and at some point we might treat it and we can put a coil in there and thrombose it. But because of the risk to the regular artery, the regular distal artery in the kidney, likely we'll take a conservative approach. So in the final minutes, just want to talk to you a little bit about angioplasty in children. We do see FMD and other lesions in children, and of course these kids are going to be growing. Their hypertension is generally much more malignant than adults who present with this problem. And just I've had a lot of experience in my career in treating children, and we generally believe this is a different form of FMD. You see a very tight narrowing here, and some post-narrowing dilatation. Very small renal arteries, so you can't really appreciate that, but you can see the artery's not much bigger, not much bigger than the catheter. The left renal artery, you can see the right renal artery is fine. The left renal artery is difficult to see at this point because there was a very high stenosis and a 70mm pressure gradient. Here you can see what that looks like, and some post-stenotic dilatation. And you can see this is a 3 millimeter balloon. Generally in a woman, an adult woman, we'd use a 6 or a 7. This was a 3 millimeter balloon. Here you can see the dilatation, and subsequent angioplasties went up in size, and you can see it was very refractive to angioplasty. And because the blood pressure was malignant in this particular patient, we wind up putting a small balloon expandable stent, and we were able to get this artery wide and cure this child of the hypertension. As they grow older, this stent may need to be increased, oversized, or dilated further, but that's something we can deal with subsequently. But it reduced the risk of stroke and other complications to a child who was growing up. As I mentioned, these fibrous morphologies are more common, and they tend to be resistant to angioplasty, and so occasional stenting is necessary. And unfortunately, surgery in these children frequently involves taking the kidney out, which we of course want to avoid. So in conclusion, the techniques and technology for angioplasty has really improved over the years. Careful technique is critical, of course, because of the presence of spasm in small arteries. Management of the aneurysms can be done concurrently or delayed, and this involves some clinical judgment and working with the patient to decide. And the procedure itself is not painful, it's important to know, although occasionally patients are aware that the balloon is being inflated at the time of angioplasty. So thank you very much, and I appreciate your attention.